Глубоко уважаемые коллеги, мы открываем наш очередной симпозиум. Он называется «Актуальные вопросы кардиологии». У нас будет 4 доклада с докладчиками, которым может позавидовать любой крупный европейский конгресс. Это звезды первой величины европейской и, в общем, даже, можно сказать, мировой кардиологии. И темы, которые мы будем сегодня обсуждать, очень широки, от фибрилляции предсердий до цифровой кардиологии. Но все они объединены, наверное, одним общим контекстом. Это очень современное представление, в том числе и в эпоху коронавирусной инфекции, очень современное представление об состоянии нашей кардиологической науки и практики. Итак, первый доклад профессор Дан Атар, представляющий Норвегию, университет Осло, который представит нам новые рекомендации Европейского кардиологического общества 2020 года по фибрилляции предсердий.
Dear colleagues, ladies and gentlemen, the title of this presentation is the ESC 2020 Atrial Fibrillation Guideline. What is new? My name is Dan Attar, Professor of Cardiology at Oslo University Hospital in Norway. First, I'd like to dedicate this talk to the Almasov Center. It is in honor of this important research center and the Russian Society of Cardiology, as well as its great leadership. Epidemiology of atrial fibrillation is a growing concern worldwide. We see here the global prevalence of atrial fibrillation distributed according to countries and areas, and obviously it is actually hitting every population in the world in an increasing degree. We have therefore this new guideline, which replaces the 2016 ESC guidelines on atrial fibrillation. And in the following slides, I'd like to show you what is the innovation of these very guidelines compared to the one 4 years ago. Very importantly, in the new guideline, a new mnemotechnic abbreviation has been introduced. It concerns the initial AFib workup, and it is abbreviated as CC and 4S and ABC. Now, CC stands for confirm atrial fibrillation, which means the diagnosis, and the second C stands for characterization of the disease in a given patient. And this is further explained by a 4S division, 4S meaning assessing stroke risk, symptom severity, severity of atrial fibrillation burden, and substrate severity, which includes the comorbidities, the substrate changes in the heart, patient age, and so on. If we look at the confirming of atrial fibrillation, well, there is a very clear clinical distinction, namely whether symptomatic or asymptomatic atrial fibrillation, it must be decremented by a minimum duration of an ECG tracing of AF of 30 seconds or an entire full-length 12-lead ECG showing atrial fibrillation. So that is the diagnostic aspect of this part. We then move to management of atrial fibrillation, simplified in the ABC abbreviation. A stands for anticoagulation, or very practically avoiding stroke. B denotes better symptom control, and C addresses the comorbidities and cardiovascular risk factors. Now, one new aspect in these guidelines is that this part, C, has been elevated to be equally important as the 2 other parts shown here. So how do we move forward with the ABC? First, we identify low-risk patients, and as I will show you shortly, the CHADS-VASc score remains in place. CHADS-VASc score meaning 0 for men or 1 for women as a low-risk population. Then offer stroke prevention if indicated, and assessing bleeding risk to address modifiable bleeding risk factors. The next step is then, of course, to choose the anticoagulation, which now preferably be a NOAC. When we are walking to the B of the ABC strategy, we need to assess the symptoms. We need to look into quality of life and not least to discuss patient preferences. Then we consider either a rate or a rhythm control strategy, which I will show you briefly. And the last one, the comorbidities and the cardiovascular risk, has received great strengthening in this guideline, and we will also look into this. This is basically the good old CHADS-VASc score as we already have seen in the 2 previous guidelines as a class 1 recommendation to utilize to assess stroke risk. Nothing has changed here, and indeed the default in avoiding stroke and in stroke prevention is to do anticoagulation therapy unless really low risk has been shown. And what does stroke prevention mean? It means oral anticoagulation, either as well-managed warfarin with a TTR over 70% or a NOAC, which is the clear preference of this, as well as, you know, the 3 last guidelines. So how does it look in the recommendation table? It's a class 1 level A recommendation that for stroke prevention in AFib patients, the NOACs are recommended in preference to vitamin K antagonists. And for risk assessment, CHADS-VASc remains in place as the preferred instrument. Also, oral anticoagulation is, of course, recommended in these populations shown here. And it is very interesting to look what the differences were in the recommendations between the 2016 and the 2020 guidelines. As you know, the AFib patients already on treatment with warfarin may be considered for NOAC treatment in the previous guideline, a relatively weak recommendation. And this has changed in the sense that the current guideline gives the strongest recommendation to say that people on warfarin with low TTR must change to a NOAC. And if this low TTR is remained, then one has to improve TTR by education and counseling and more frequent INR checks. So this is a more differentiated approach. Now, very interestingly, if you remember the 2016 bleeding risk assessment, actually the Hasblach score was abandoned, and it was not a completely strong recommendation regarding the bleeding risk score, but the Hasblach score has now received a revival in the new guideline, has a strong recommendation to utilize, but for the same purpose, namely to address modifiable bleeding risk factors in all atrial fibrillation patients and to identify patients to have a high bleeding risk, to have more often clinical review and scheduling. Because the bleeding risk assessment should never discourage the use of SPAF, of stroke prevention in atrial fibrillation. It's very interesting to see how CHADS-VASc risk factors modify over time. Here you see an assessment of last year, or patients been followed over 14 years, and how these various risk factors tend to be more prominent in the CHA2DS2-VASc assessment. And not surprisingly, as the years pass, more and more patients will have more and more prevalence of these risk factors, particularly the upper ones, such as hypertension, of course, age, congestive heart failure, and diabetes. And therefore, it has come to a recommendation to say that risk assessment needs to be redone at periodic intervals so that we don't miss an increase of risk. And this is a strong recommendation, as you see. Now, another aspect of this, and also the previous guidelines, is the integrated atrial fibrillation management, where physicians inform patients about the options of diagnostics and treatment. Placing patients in a central role has already been advocated in 2016 with a moderate recommendation. But as you see now, this is absolutely recommended and strongly recommended, that the discussion and the shared decision making with the patient and the relatives has come to stay. And this is very nicely presented in the integrated AF management slide shown here, where we again have the optimized stroke prevention, then symptom control with rate or rhythm control, and then management of cardiovascular risk factors. We are basically back in the ABC strategy. And as you see, patient education and self-management, a lifestyle modification, and other factors are strongly integrated now in this holistic integrated management. So we must not forget that AF presents itself in a number of symptoms and expressions. You see very well that it remains asymptomatic or silent in many patients, but when symptomatic, you have a number of possible effects, including depression, poor quality of life, cognitive decline, and so on. All these we need to keep in mind when we approach a patient and what we can do to ameliorate the disease. I'd like now to raise your attention about one specific aspect, which is rhythm control in atrial fibrillation. Rhythm control is really having a strong recommendation with a high level of evidence. And I may say in this guideline, it has even been strengthened as compared to the previous guideline, partly because the technology of ablation has been perfectionized over the years. Hence, rhythm control therapy is recommended, but we must remember this recommendation is purely symptom-driven and relates to quality of life improvement in symptomatic patients with atrial fibrillation. How about the cardioversion aspect? Most of the rhythm control strategies do actually start with the cardioversion, and you see here the various agents such as vernacalant, amiodarone, electrical or pharmacological being recommended, and pharmacological cardioversion indicated in hemodynamically stable patients. All these are very strong recommendations. And we move on to see how these changes that I just mentioned have materialized between 2016 and 2020. It was a 2A recommendation that catheter ablation or surgical ablation should be considered in patients with symptoms. And we have now the class 1 for AF catheter ablation for pulmonary vein isolation is recommended for rhythm control after one failed class 1 or class 3 antiarrhythmic drug to improve symptoms of AF. This is pertinent to patients who have paroxysmal AF or persistent or long-term persistent AF with major risk factors for recurrence. And further, AF ablation should be considered, was the text 4 years ago in symptomatic patients, but now it is even recommended with a class 1 when we have reverse LVD function that can be achieved by ablation. For example, a condition that we see quite often, tachycardia-induced cardiomyopathy, should also be considered in selected atrial fibrillation patients, even then when they have reduced EF heart failure. This aspect has not been so clear last time. And we now go to the lifestyle modifications, which again have been upgraded from this moderate recommendation in 2016 for obese patients, weight loss, and this is now a clear recommendation for going aggressively towards weight loss in these populations, and also risk management after AF catheter ablation. The last recommendation was moderate to anticoagulate for at least 8 weeks, and now it says NOAC or warfarin should be used at least 2 months after the ablation and then continued according to the patient's risk profile. Indications for catheter ablation are very nicely shown across the entire field for symptomatic AF patients. You see here that the various types of AF are shown on the top, and you see how prominent the patient choice has been placed in this flowchart. And then we have the option for all these scenarios, either to choose antiarrhythmic drugs down the road or to choose catheter ablation, which you can see for each of these have various recommendation colors. Then failed drug therapy again can trigger a new decision, even if patients, for example, had antiarrhythmic drug for years. You can still decide whether you switch them to perform catheter ablation as shown here. And indeed, long-term rhythm control therapy by antiarrhythmic drugs has been relatively stable throughout the years. We know as we go from the left to the right with increasing structural heart disease that we have less and less to choose from in terms of the agents we can use as antiarrhythmic drugs. Only amiodarone is indeed safe for heart failure with reduced ejection fraction, as an example. That moves us to the last item, which is the comorbidities and the risk factors. You see that many of these aspects, such as hypertension, obesity, alcohol, OSA, sleep apnea, all these factors will diminish the chances that an ablation or an antiarrhythmic drug therapy will be successful over the years. And therefore, a comprehensive risk factor management is now recommended. This brings me to my conclusion. Dear colleagues, ladies and gentlemen, it's my personal view about what the ESC guideline provides as innovation. Number one, the guideline delivers a more structured approach to the atrial fibrillation theme by and large, using new mnemotechnical abbreviations which are easy to remember: the CC, the 4S, and the ABC. Patient involvement and decision-making has been very much strengthened again in this guideline. There is basically unchanged recommendation pattern regarding stroke prevention in atrial fibrillation, except that more and more the option to switch a patient from warfarin to a NOAC is being recommended, particularly in those who have low TTR. There is, in my view, a general strengthening of rhythm control strategies in the wake of the excellent techniques we have today with pulmonary vein isolation. The guideline, of course, keeps the importance of well-performed rate control strategies. And finally, there is a holistic, integrated approach to a patient's comorbidities, risk factors, and lifestyle changes. I would like to thank you for your attention and hope that the Almasov Center will have a live meeting next time.
Прекрасный доклад, очень дидактичный, очень детальный, коллеги. Согласитесь, как странно, за 40 лет последних, вот я думал об этом, фибрилляция предсердий превратилась из довольно узкой проблемы контроля за частотой сердечных сокращений у больных с постоянной формой мерцательной аритмии и удержанием теми или иными способами синусового ритма мультидисциплинарную проблему. Этому во многом поспособствовали, конечно, представления роли фибрилляции предсердия в возникновении нарушений мозгового кровообращения, появление новых антикоагулянтов и, разумеется, новые методы лечения, которые, вот как мы видим, в 2020 году катетерная абляция и изоляция легочных вен стала рекомендацией. Как бы к этому ни относиться, мы понимаем, что достаточно большая частота рецидивов все равно. Вот в нынешних рекомендациях это, в общем, пожалуй, основной путь к лечению интервенционному этих пациентов. Но нам надо двигаться дальше, и следующий доклад представит очень известный человек, профессор Фаусто Пинто из Португалии. Он является деканом медицинского факультета в университете Лиссабона. Это экс-президент Европейского кардиологического общества, и сегодня это избранный президент Всемирной Федерации сердца. И Фаусто Пинто поделится с нами соображениями по поводу сочетание коронавирусной инфекции и сердечно-сосудистых заболеваний. Очень острый вопрос для сегодняшнего дня. Пожалуйста.
Hello, dear friends from Almasov Institute, my dear Professor Sladkov, dear Evgeny. It's a real pleasure, a real honor to be part of your celebration of your 40th anniversary of this big institution that it's known everywhere around the world as an excellent example on how to do good medical practice, good research, good teaching. And I'm very happy also to have established this special relationship with you and also between our two institutions. I just want to remind you here that I was present actually there, and I would love to be there as well at this time when for your 35th anniversary. And there was a big honor for me also to be there. And at that time, personally, to share all the different things that you showed and the atmosphere. That was really a fantastic moment. And then, as you know, we established this very special relationship and this collaboration. And I'm very happy. This was when you visited us a couple of years ago. And I'm sure that we will continue to work together and to make sure that we do our best for our communities, our patients, our students, our colleagues. And I'm really very, very grateful and very happy to be part of this celebration. Congratulations, and keep up with the excellent work that you have been doing for science, for cardiology. And that's certainly something that I'm very proud of being your friend. But let's talk a little bit about the topic of the moment, which is COVID and this pandemic that we are living in. These are the numbers from last night. We are close to 40 million people infected, known to be infected. We know it's much more than that. And over 1 million deaths globally. And if you look at the map of the world with the distribution of cases, we can see that, as we all know, it started in China, then moved to Europe, and then went to the American continent, and now it's back in Europe. And actually, we are facing now what many call the second wave. And you can see here the dark colors, meaning that we have very high rates now, prevalence of cases. It's increasing. We are all very much concerned with the winter and also the concomitant existence of influenza virus and many of the other conditions that may actually affect how we're going to handle this. One of the big questions and one of the realities that we faced and we understood at an early stage was the fact that patients with COVID, they had a higher prevalence of cardiovascular comorbidities, meaning that, and that was clear from the beginning, that patients with cardiovascular disease, they had a higher rate of developing the disease, and they also, when they developed the disease, they had a higher chance of having a complication. And here we have data from some of the studies, many of them coming from China, from Italy, from the US, that basically showed a prevalence of comorbidities among all patients that were admitted with COVID, around 25%, up to 25% overall cardiovascular disease comorbidities. But if we go just for hypertension, it can go up to almost 60%, diabetes around 30%, up to 30%. And in some cases, there is also a correlation with obesity, particularly from some of the American studies. So it's really an issue that we have been facing, and therefore it's been something that we as cardiologists have been dealing with. Well, we know today more about the virus, and we know more about how it can affect the cardiovascular system. We know that there are some underlying comorbidities that will affect the prognosis, the presence of hypertension, coronary artery disease, or diabetes. This can actually not only increase the susceptibility of the individual patient, but also to be responsible for increased severity of the disease, and also for being elements that can be related with the development of some potential complications like heart failure decompensation. And on the other hand, there can be a direct involvement of the cardiovascular system by the virus. So acute cardiac injury, which will be reflected on the increase in the troponin level, or even myocarditis with a direct infection by the virus, and I will show you some examples of that. It can be responsible for also acute coronary syndromes, arrhythmias, and thromboembolic phenomenon. That's actually something that has been now clearly described. In some patients, they have a prothrombotic condition that induced by the virus that will be responsible for some thromboembolic phenomenon. One other element is the role of some cardiovascular drugs, and I will address this as well. There was some question about the use of ACE inhibitors and ARBs, which is more or less clarified now, but there was some questions because, as we know, the virus links to the ACE receptor, and because of that, that's the way it gets into the cells, and particularly into the respiratory system, and that's why there was some concerns about the use of some of these drugs. We are now facing also what is called the long-term effect, and I will talk also a little bit about that. This so-called long-haul COVID, so patients who develop not only the acute disease, but with some persistent symptoms, and that's something that we are now facing as well. Another interesting development is what is shown here, and this was published recently. This is an editorial by Peter Levy and Tom Lucier, focusing on the concept of how the virus, by involving the endothelial cells, can actually have an impact in terms of understanding some of the pathophysiology that underlines the infection and how it affects the cardiovascular system. We have here in this area a normal resting endothelial monolayer, and we can see here the different areas that and basically responsibilities, let's put it this way, that endothelial cells have in normal function, like being responsible for some anticoagulant or anti-aggregatory tasks, profibrinolytic, anti-inflammatory, intact barrier function, vasodilator, and antioxidant. And what happens when there is the infection of the endothelium, and we know now, and that has been shown, that the virus can actually affect the endothelial cell, infect the endothelial cell, and develop what has been called also as endothelitis. And this will basically create some sort of disruption or activation of this endothelial monolayer, and it will be responsible for instance, some procoagulant or pro-aggregatory responses through some tissue factors, thromboxane, ligands, and so on. Also be inducing some antifibrinolytic response by the PI1, pro-inflammatory, like expressing leukocyte adhesion molecules, producing chemokines, and recruiting leukocytes. Impaired barrier function, and this is very important because some of the clinical manifestations that we are seeing, particularly in the brain, they may be related with this fact, and also being responsible for some vasoconstrictor effect and pro-oxidant, which all of these may, in a way, be the underlying pathophysiology that underlines some of the clinical manifestations that we are seeing in some of these patients. So there's been some increase in the understanding and focusing now in some concepts related with how the disease affects the endothelium and how these endothelial changes may actually be responsible for some of the abnormalities that we are seeing in these patients. Now, we have also data now showing that the fact that the heart is involved and there is some concomitant cardiovascular involvement, it does have an impact in terms of outcome. This is data coming from Italy and basically showed that looking at cardiac biomarkers on admission among cardiac patients, the patients who had higher levels of high sensitive troponin or NT-proBNP, they had worse outcome. And actually, when they went to look at the difference between the patients who actually died and the patients who survived, the patients who died, they had higher levels of both troponin and NT-proBNP, representing basically markers of myocardial injury. So the presence of myocardial injury is a risk factor for worse outcome in patients infected with COVID. And here you can see that when you do this Kaplan-Meier curve, you can graphics, you can see that the patients with no cardiac disease, they had a higher survival rate compared with the patients with previous cardiac or with concomitant cardiac disease. And if you look here at mortality, you can see that the patients with cardiac disease, they had more than double mortality compared with the patients without cardiac disease, meaning that the presence of concomitant cardiac disease is a risk factor in these patients, therefore representing, that's why it's so relevant to identify these patients in these conditions. As I mentioned before, we have now also evidence that the virus can infect the myocardial cell. And this is a report published a few weeks ago in The Lancet in an 11-year-old girl who was infected with the virus and who developed one condition, which is not very frequent, but when it occurs, it can be very severe, like in this case, that resulted in the death of this child. This is the so-called COVID-19 related multisystem inflammatory syndrome. And what you can see here is actually the virus inside the myocardial cell. So this is the evidence that there can be direct injury of the myocardial cell by the virus, producing severe disease. Another interesting observation was published also recently, and this study was actually in asymptomatic athletes that were infected by the coronavirus. All of them have been subject to MRI, and what it showed was in about 1/3 of the patients, there was some evidence of myocardial involvement. And again, these were patients who were totally asymptomatic or very mildly symptomatic, but they were infected. And in about 15% of the patients, they actually had evidence of myocardial injury. And this is actually something that can be very relevant because we have been seeing rare cases, but a few cases of sudden death in athletes or performing high-level exercise. And this may be the reason why this may develop in some patients. So this is a call to be more careful and aware that even asymptomatic athletes that have been infected, they may develop disease and they may develop some abnormalities that potentially may have an impact in terms of outcome. And this may be relevant, for instance, for indication for restrictions of activity, for instance, if the patient has this type of abnormalities. We know that in myocarditis, we usually use the 6-month rule that the patient should not exercise or should not do strenuous exercise for at least 6 months. In this case, this might be, and of course we still need to have a little bit more data, but this may indicate that we may need to assess particularly athletes to see if they have these abnormalities, because this may have to impose some restrictions on the physical activity of these athletes. Now, as I mentioned, one other question was about the use of some drugs, and particularly at the beginning was questioned the use of ACE inhibitors and ARBs because of the risk of potential risk of increasing either the likelihood of a patient being infected, or if being infected, of the severity of disease. And there was a question about this. Well, there are many studies now, and I'm showing you here one study we did, my group did, and basically what we did here was a systematic analysis, and what it showed was that there was basically no difference. And so the conclusion was that in our systematic review with meta-analysis, there is no suggestion that the exposure to ACE inhibitors or ARBs increases the risk of having the SARS-CoV-2 infection or developing severe stages of the disease. And I think this is quite comforting because, as we all know, we have a lot of patients doing these medications, and there are actually already some recommendations from the scientific societies saying that patients taking this medication, they should not stop it, they should continue. And we have now, I think, reasonable data to show that this is consistent with this recommendation. What also has been shown over time was actually an improvement on the way these patients are handled. And here we can see the results in patients admitted to the ICU and the difference in time when the patients were admitted in April and then when they were admitted in May, June. So there's already some evidence that the better knowledge about how to manage these patients actually had an impact on the way on outcome. And what we see here in blue, April, in May, June, we see this brown, and we can see that the survival rates increased just in a couple of months, meaning that we are better equipped now to manage these patients. And this was especially more relevant in this group of patients over 50 years old, which, as we know, is also the group of patients with a higher risk and belong to the risk groups that may develop more severe disease. Now, as I mentioned before, one important element that is being now seen is the fact that some of these patients, they actually develop chronic symptoms. And this is what has been called the long haul COVID. And it's also clear that now we do have some cases where it becomes some sort of a chronic illness, particularly complaints like fatigue, cough, headache, loss of taste, smell, but even shortness of breath, chest pain, or confusion, they may persist for some time. And we have to be aware of this. And this is a reason also why we have to mitigate as much as possible the dissemination of the infection. Now, a word on the indirect impact of the disease in cardiovascular patients. This is coming from Italy again, and it showed that during the period, particularly the peak period, there was a significant decrease in the admissions for acute myocardial infarction, about 50% reduction, with an increase in case fatality rates, in mortality, which almost tripled. And again, this was basically due to the fact that that the people were afraid to come to the hospital, to the emergency room. We did see that also in our clinic, in our hospital, and this is something that we have now to change, particularly now that we are facing another wave of these patients, and we need to create trust in the population so they are not afraid of coming to the hospital, because that's very important, because we can treat these patients properly if they come on time. If they come late or if they don't come, then the prognosis is much worse. The same in Austria, they observed exactly the same thing. In the US, you can see here what was the expected admission rate of patients with myocardial infarction compared with the previous year, and there was a significant drop this year related with the increase in the number of COVID cases. We saw the same in my hospital. In March, we had the first case, 2nd of March, and then there was a significant decrease in the number of patients coming to the emergency room, significant decrease in primary PCI, PCIs, even just coronary angiographies were substantially decreased. And this brought this kind of highlight from the media. Heart attack victims may be dying because of coronary virus fears, and this is something that we really have to face. We do have also data now coming from the US that showed about 20% reduction in the acute myocardial infarction associated hospitalizations, and the observed mortality was much higher than the expected mortality, precisely because of the fact that the patients were either not coming or coming too late. And we can see here the drop related with less admissions because of fear of the patients. This is coming from Hong Kong, basically showing that during the period of the pandemic, there was a substantial increase on the time from symptom onset to first medical contact, door to device, cath lab arrival to device, meaning that the patients are coming late, and that this is very important that we now face this and that we try to at least minimize the impact, particularly now that we still are not rid of the pandemic. And here there was a survey by the European Society of Cardiology, a global survey, basically showing the same thing. About 80% of the hospitals globally, a little bit of difference among the different continents, but basically showed that there was a perception and in reality a significant decrease in the percentage of patients that were admitted with STEMI and patients that presented later than usual, again demonstrating that the patients were afraid of coming and they either will not come or come too late. This has an impact, and we already have data also showing that there is an excess of deaths, and this is coming from the US. Of course, this excess of deaths, part of it can be explained by the COVID patients, but there is a big chunk, and here we have in dot lines, we have the expected mortality, in dark line, the observed mortality, and here in orange, we see the number of patients that were dead because of COVID, but there's still a big part of the deaths that could not be explained just by the COVID, meaning that there were a lot of people dying. That was expected, of course, because by the fact that we have an increase in the number of patients that have to be treated, there's always going to be some sort of increase in global mortality, but we need to understand where we can minimize this impact under the current circumstances, because really we are now watching what can be called a wave of heart disease. So in conclusion, I would say that we know today that cardiovascular disease is a major complication and also cause of death in patients with COVID-19. Patients with cardiovascular disease have a high likelihood of being infected. In the presence of myocardial injury is a marker of poor outcome. Cardiovascular departments, they had to adapt during the COVID-19 pandemic, which has been responsible for direct and indirect mortality and morbidity. And certainly cardiovascular disease has been one of the important collateral damages of this pandemic. And that is why it's so important that we revise some of the strategies that we had at the beginning of this pandemic that we can change now in order to be able to accommodate these patients and be able to treat not only the COVID patients, but also the non-COVID patients. And with this, I will finish. Again, congratulations, happy birthday for the Almazov Center, my dear Evgeny. It's really been a privilege to know you, to work with you, and I wish you all the best for the future. Спасибо.
Прекрасный доклад. Как странно, коллеги, мы наблюдаем за эпидемией, участвуем в ней уже несколько месяцев. И вот от представления о том, что больной с сердечно-сосудистой патологией совершенно логично имеет больший риск умереть от коронавирусной инфекции, мы приходим к пониманию, что, по сути дела, Коронавирусная инфекция – это воспалительное заболевание сосудов, воспалительное заболевание эндотелия. Вот это очень интересный вывод, который можно сделать из лекции профессора Пинто. И, конечно, по-видимому, нас ожидает всплеск сердечно-сосудистых заболеваний. Второй очень важный вывод, который я бы сделал, это то, что бессимптомное течение очень опасно, в том числе для молодых людей, для активно физически развитых, которые продолжают, возможно, тренироваться. И вот те молодые люди, которые полагают сейчас, что их это не коснется, что легкий насморк – это не проблема, вот это очень важное обстоятельство. Ну и последнее, что я хотел бы подчеркнуть, это, конечно, чрезвычайно длительный период реконвалесценции у тех, кто излечился от коронавирусной инфекции. Вы видели, что он может затянуться на недели и месяцы с достаточно выраженной симптоматикой. И это должно учитываться врачами всех специальностей. Переходим к следующему докладу. Профессор Белла Меркеле, представляющий Венгерскую республику, это экс-вице-президент Европейского кардиологического общества, и он выступит с докладом об адаптации сердца к нагрузкам в контексте риска внезапной смерти. Пожалуйста.
Dear colleagues, ladies and gentlemen, it's a great pleasure and honor to be sorry, just start again. Dear colleagues and friends, it's a pleasure me to be invited to the third Innovation St. Petersburg Medical Forum and Scientific Session. First of all, I would like to congratulate to all of you to your 40th anniversary at Almazov National Medical Research Center. So my title is Cardiac Adaptation to Exercise. What about the risk of sudden cardiac death? Is there any clear data for the decision, eligibility, or disqualification? So I am a team physician of Hungarian national swimming team, member of the FINA medical committee, and I was the chief medical officer in FINA 2017, since I'm very much interested in any kind of sport cardiology. So it's a great pleasure me to be invited on that topic. Sudden cardiac death is a common story. Unfortunately, it's happened almost every day worldwide at the age below 35, and mostly during exercise or competition. Unfortunately, the success rate of resuscitation is very poor. So our major question is actually whether competitive sport associating with an increased risk of mortality. We do have evidence that obesity, high blood pressure, diabetes, and risk of cardiac coronary artery disease is decreasing with the sport. The coronary reserve of the coronary arteries and the functional capacity are much better in that patient population, in that people. On the other side, if the top athletes had a higher physical activity, troponin positivity could be occurred, and the risk for sinus node disease and atrial fibrillation significantly increasing. We do have imaging studies which clearly demonstrating myocardial fibrosis, right ventricular dysfunction, and even calcified coronary artery disease. So it seems to be a U-shaped curve. If we look at the causes of sudden cardiac death in athletes below 35 years, there are typical cardiac diseases. First of all, I would like to show some differences between United States and Europe. Maron and co-workers published in Circulation in 2006 a big patient cohort with sudden cardiac death. The major cause of sudden cardiac death in US was hypertrophic cardiomyopathy, coronary anomalies, myocarditis, channelopathies, WPW syndrome, dilated cardiomyopathy, aortic stenosis, coronary artery disease, immediate left ventricular hypertrophy, and sometimes they found probably accidentally intramyocardial left anterior descendant. On the other hand, in Europe, we do have much higher proportion of arrhythmogenic right ventricular dysplasia. That's the major difference, and less hypertrophic cardiomyopathy. So if we calculate the potential risk, it seems to be that intensive physical training improve the risk of sudden cardiac death by 2 to 3-fold. So the incidency of sudden cardiac death in athletes in younger age is around 1 to 3 per 100,000 per year, and it is more frequent in males. As I already mentioned, the main cause of sudden cardiac death below 35 years is the structural heart disease. Just go back a little bit in the history of cardiology, and we had the first data coming from a 24-hour Holter recording published by Baez de Luna in American Heart Journal. There was a big patient cohort in which we had sudden cardiac death during Holter recording. And in that patient population, the most common cause leading to sudden cardiac death was ventricular tachycardia in 62%, primary ventricular fibrillation 8%, and toes at the point VT in 13%. Only in 17% of the cases caused by bradycardia. So are the different sport actually different in causing sudden cardiac death? So if you look at the patient cohort with sudden cardiac death among top athletes, you can see we have quite a big number among football and soccer player, basketball player, runner, most common in swimming, aerobic, rugby, tennis, etc. But if you look at the different countries, in US, the most common cause, most common sport among sudden cardiac death survival, American football and basketball. And sudden cardiac death is more common in soccer player in Europe. And everybody knows that badminton is very popular in Malaysia. And that's why we have the highest proportion of sudden cardiac deaths in Malaysia among badminton players. So of course, the number of athletes can influence the total number of sudden cardiac death episodes in different sports. Much better to prevent sudden cardiac death than cure, because unfortunately, we have very bad experience in treating sudden cardiac death among top athletes during exercise and even about competition. Much better to prevent. There is a need for basic examination in all athletes, and probably for professional athletes, detailed cardiological screening is necessary. Of course, this type of basic life support cannot achieve any success, unfortunately. So our very young soccer player died during the competition. There are no widely accepted standard guidelines at the moment. Let me show you two different guidelines, one coming from US and other from Europe. The American guidelines are more conservative. It's focused on history and physical exam. Further workup only necessary if the risk factors are identified. That's the so-called US approach. In Europe, we have additionally an ECG. But there are some questions regarding sensitivity and specificity and cost effectiveness. So let me show you two recent guidelines. I had the opportunity to participate in the European one. So if you look at the pre-participation screening among young competitive athletes, after having the family and personal history, physical examination and 12-lead ECG should be carried out. If all results are negative, these young athletes is eligible for competition. If we do have some positive findings, further examination, echo, stress test, 24 Holter, cardiac MRI, coronary angio, electrophysiological studies are necessary to prove the question. So in my department, we have at least 10 years scientific experiences in sport cardiology. We had several research grants and we perform an intensive publication. We have over 40 scientific papers in Q1 journals and several international abstracts. We have very widely had the opportunity to cooperate with big centers like Mayo Clinic, Sport Cardiology, or University of Physical Education, and other sport federation. So as I already mentioned, we have more than 300 top athletes annually with different results. So we collect all of the questionnaires, the results of physical examination, 12-lead resting ECG, laboratory examination, echo exercise test, cardiopulmonary exercise test, and if it's necessary, we continue with Holter ECG, blood pressure monitoring, cardiac MRI, CT, or EP. So we know that intensive training causes cardiac adaptation at 3 levels. That's the so-called athlete's heart, at electrical, structural, and functional level. Intensive training can cause bradycardia, repolarization abnormalities, voltage changes, demonstrating chamber enlargement. In structural, if you investigate them with imaging, increased chamber size thickness and valve thickness. And there are some functional changes like enhanced diastolic feeling, augmented stroke volume, and of course, high peak oxygen consumption. The main goal of sport cardiology screening is to differentiate between physiological and pathological cardiac adaptation. Our goal is to diagnose the pathological changes and diseases and minimize the risk of extreme physical exertion, to assess cardiopulmonary and metabolic status, and optimize the training program to gain the best performance. So again, detailed cardiology screening, questionnaire, physical examination, resting ECG, echo, additionally ambulatory blood pressure monitoring, Holter, CMR, CT, and cardiopulmonary exercise test. Let's go to our basic investigation, ECG. If you look at the ECG, there are some borderline ECG findings like left axis deviation, left atrial enlargement, right axis deviation, right atrial enlargement, and complete right bundle branch bone. The abnormal ECG findings are the T-wave inversion, ST segment depression, pathologic Q-wave, complete left bundle branch block, QRS wider than 140 millisecond, epsilon wave, ventricular pre-excitation, prolonged QT, Brugada type 1 pattern, profound sinus bradycardia, PR interval longer than 400, MOBITS 2, third degree AV block, and more than 2 PVC after each other, atrial tachyarrhythmias and ventricular tachyarrhythmias. No question, further evaluation required in that cases. Let me show you some physiological change. This is the so-called early repolarization, but we do have a significantly higher proportion of bradycardia among athletes and the sign of left ventricular hypertrophy. The potentially pathological ECG signs in our cohorts demonstrating much frequent T-wave abnormalities, ST abnormalities, and pathological left ventricular hypertrophy signs. If we look at Holter ECG, we have higher proportion of ventricular premature beats, non-sustained VT, but significantly higher difference in ST abnormality and QTC abnormality. And this is a very nice example which can occur among top athletes, a transient third degree AV block during the night, which has no consequence. So let me show you a very nice story. This is a Rio Olympic game. I was a team doctor of the Hungarian team, and Tingarosu won 3 gold medals, and he had also 2 world records. The very, very robust record was achieved during the 400-meter medley, and you see how effective is actually or support by the team doctors. So she won 3 gold medals and she won. Can show you. That was only a relaxing figure, but go to our scientific part. So the role of cardiac imaging in athletic screening is just to find the morphological and functional characteristic of the athlete hearts, to distinguish physiologic form from pathological sport adaptation, and to investigate the adverse effect of extreme exercise training. So we do have a differential diagnostic program in everyday problems in everyday praxis. We should differentiate between hypertrophic cardiomyopathy and physiologic left ventricular hypertrophy, between left ventricular non-compaction and physiologic left ventricular hypertrophy, between arrhythmogenic right ventricular dysplasia and physiologic ventricular dilatation, dilative cardiomyopathy, and physiologic ventricular dilatation. We always have a green area, which is quite difficult to solve, but we do have some everyday used option just to make difference between pathology and physiology. Echo plays an important role. Physiologic training induced functional and morphological change can be investigated. We can differentiate from pathological form, and we have sometimes a combined effect of pathological forms and exercise-induced remodeling, which makes our task much more difficult. This is coming from one of our paper published in Good Scientific Journal, that there is a big role for twist mechanism for achieving the maximal output of your left ventricle. There's always an apical and basal rotation, and these together in absolute value causing the twist, which contribute to the function of the heart. Another difference between the control and top athletes, the top athletes has a clear diastolic supper function. What does it mean? So if you compare athletes with controls and patients suffering for hypertrophic cardiomyopathy, sometimes you can see quite similar systolic function, but if you look at the diastolic function, there are clear differences and especially between athlete and hypertrophic cardiomyopathy. So if anybody has a good diastolic function, no question, less evidence for hypertrophic cardiomyopathy. Another important question is the valvular disease. This is quite often, if you look at tricuspidal mitral pulmonary aortic regurgitation, and the regurgitation degree and morphological and functional alteration influence our decision. If an athlete had a mild or moderate regurgitation with relatively acceptable left ventricular diameter, less than 60 millimeter, no limitation, the athlete can continue his activity. But if the mild or moderate regurgitation associated with slightly dilated left ventricle, there are some limitations. And if it's a severe regurgitation, the patient and athlete should be disqualified. We very often use MRI just to make the differential diagnosis. But for that, there was a need to find the so-called average normal value and to make a difference between healthy volunteers and normal athletes. And this curve demonstrating the difference. So if we do have athletes, the so-called left ventricular mass indexes in males around 100 gram per square meter, and this is only 67 in healthy volunteers, so a clear difference. And we also can measure the left ventricular mass by trabecular quantification method, demonstrating the cardiac adaptation depending on different sports. So if we have technical sport like kickboxer, it's quite different compared kayak canoeist or water polo player. They have a much robuster left ventricular mass index. So let me go to our everyday clinical question. What about the eligibility and disqualification in specific cases? So let me start with clinical cases. So case one, this is a case with elite male swimmer. He is Olympic champion, 3 times world and 2 times European champion. We had the first visit at the age of 21. After having 7 years follow-up, there was a clear change on the ECG, no symptoms. This elite male swimmer had more and more ventricular premature beats and couplets and triplet with the follow-up. Before Olympics, it was 9.5. There was no time just to investigate more. I followed the athletes carefully during Rio. And after Rio, we had a 6-week deconditioning, which has less effect on reducing left ventricle excess systole or right ventricle. And we performed an ablation, and the final results was 3%. So we had left and right ventricle outflow tract excess systole, which was difficult to cure. We went for an MRI, which demonstrated a normal left ventricular function. After deconditioning, the left ventricular volume and mass decreased. Right ventricle, almost normal, but slightly reduced, 39%. A little bit dyskinetic right ventricular outflow tract. After deconditioning, right ventricular volume slightly decreased, but still right dominant dilatation. So the question is whether we had to disqualify or no. So we heavily discussed it with any other experts in Europe, and we decided not to disqualify it because there is no clear evidence for structural heart disease, no clear evidence for arrhythmogenic right ventricular dysplasia. And another case, a male cyclist at the age of 23 had palpitation and pre-syncope during exercise and competition. The ECG during exercise ECG demonstrating an initiation of ventricular tachycardia, and the MRI proved a biventricular arrhythmogenic right ventricular dysplasia, which is a significant structural heart disease. After 3 months, the conditioning reverse remodeling is clearly visible, but the right ventricular parameters are still in the pathological range. So it's clear sign for structural heart disease. Do we disqualify or not? Of course, yes, because there is a clear sign and there's a risk for progression. After 3 years of follow-up, no progression on the images, so it was a good decision. A patient is in a good condition, and we saved the life of the patient. Another allied male cyclist at the age of 33, palpitation during exercise, a biventricular RVD was found after having 4 times ablation procedure. We were not able to cure the arrhythmia. We decided to implant an ICD. The question whether need to disqualify, clear structural heart disease. So unfortunately, we have to disqualify our patient. The patient was disqualified from elite sports, but he is still doing regular and intensive training as a master athlete. And opposite to the other case, there is a clear progression after 4 years. Another acute example, I got a call, persistent chest pain, fatigue after being hit in the chest by a soccer ball during a National League game. So I was on duty. I performed a coronary angio, which was negative, but this ECG was quite typical, and we thought probably this is a LED dissection. It was not the case. MRI showed edema in the apical septal segment, reflects acute injury, and myocardial necrosis in the same location on left gadolinium enhancement. After 6 weeks, ECG normalized, CMR showed focal LGE persisted, edema was not longer present, and patient was advised to refrain from sport active only for a month. The question, after a month, should we disqualify or not? Of course, no, because there is no further risk for progression. Case 5, world champion, elite water polo player at the age of 34. Unfortunately, he's a smoker, no other risk. If you look at the ECG, there's a clear sign for ST elevation, and laboratory results showed increased high sensitive troponin. We immediately performed a coronary angio demonstrating LED plaque rupture with a thrombus. We aspirate the thrombus and implanted and bioabsorbable stent. After performing a cardiac MRI, demonstrated apical wall motion abnormality with edema, demonstrating acute injury. The necrosis was less than 5% of left ventricular mass. Coronary CT after 4 months demonstrated very nice results. So shall we disqualify or not? That's a very important question. But of course, clear evidence not to disqualify the patient and just go. There is no significant coronary disease anymore. Young female judo player at the age of 15, sports since 2011, Hungarian national champion, free of complaints. Positive family history. The father has a hypertrophic cardiomyopathy after aborted death, got an ICD. Genetic test was performed, demonstrating heterozygous hypertrophic cardiomyopathy, echo normal, Holter normal, cardiac MRI normal. The diagnosis is genotype positive, phenotype negative, hypertrophic cardiomyopathy. Shall we disqualify? Of course, no. But of course, we have to carefully follow up the patient. A professional Afro-Caribbean basketball player at the age of 25, since 2009, previous NBA player, had 4 times fainted during training without loss of consciousness. The patient was evaluated at Mayo Clinic, and they had a diagnosis non-obstructive genotype negative hypertrophic cardiomyopathy. Tilt test was positive, loop recorder implantation, and they found during a recurrent fainting a 5-second pause of vasovagal origin, sinus tachy, sudden drop, heart rate to 60, 5-second pause, sinus rhythmus went back. The Mayo Clinic decided to allow him to continue sport activity with defibrillator presence at the training. Primary prevention ICD implantation is not necessary. Relatively low arrhythmia, that was the decision. So this patient came to Hungary to be a professional basketball player. We had this ST depression. If you look at the echo, there's a clear apical type of hypertrophic cardiomyopathy, which associated a limited exercise capacity. There was no sign of cardiac sport adaptation. MRI sign show a non-ischemic left ventricular and right ventricular myocardial fibrosis, which showed a significant progression. Our suspicion was the typical hypertrophic cardiomyopathy, an atypical form, but other disease could not be excluded. We had to find a very rapid decision whether we need to disqualify or no. So it was a heavy discussion, and at the end we disqualified according to the law, which is much more strength, much more conservative than the US one. So that means we do not allow the decision of the patient, and the patient cannot contribute with accepting the risk of dying suddenly that way. So case 8, elite handball player, 35 years old, Hungarian goalkeeper, gold medalist at the handball championship, Olympic fourth place, had a known bicuspid aortic valve, first control at the age of 36, aortic root and ascendant dilatation seems to be stable. It was 48 times 44, similar 46, 45, no progression. If you look at our ascendant aorta, it was a very big guy. So he is a big guy actually. So we also try to find out the aortic index by square meter. This MRI show you the patient image. So if you look at the results, there is no clear progression, no aortic stenosis, and the aortic regurgitation fraction is 5%. So there's a need for disqualification, of course. No. Elite female handball player, 27-year-old, ECG show LBB and single monomorphic ventricular extrasystole. We performed a right ventricular outflow tract ablation, and after having the control ECG, no more ventricular extrasystole could be found, and MRI showed no structural myocardial disease, no late gadolinium enhancement. So in that case, no need for disqualification. Case 10, a 25 years old patient, 6-year follow-up, had a coronary CT because of atypical chest pain, demonstrating an aberrant intra-arterial left main without the compression of aorta and truncus pulmonalis. So we decided not to disqualify. We were not able to show any compression. That's why the patient can continue his activity. This is another case, an elite young soccer player at the age of 60. He underwent in another hospital detailed cardiac evaluation due to dyspnea and fatigue in the past during exercise. And he had many aborted sudden deaths during the game. So He was resuscitated 11 times during the match and transferred to our hospital. Basic life support started immediately, advanced life support in 15 minutes, CPR lasted 60 minutes, negative family history and personal except the fatigue during exercise. The troponin was high, and it was an interesting coronary angio demonstrating a left main coronary anomaly. The left main is originated from the right coronary artery, then goes between the aorta and truncus pulmonale, and it was severely compressed. And the ischemia, the huge ischemia, caused the sudden cardiac death. And this is a very typical case for life-threatening coronary anomaly. There was an acute cardiac surgery with the help of ECMO. Lad-Lima bypass was performed, and after successful treatment and rehabilitation, we did not disqualify him. 3 weeks after the operation, he left. Regular follow-up after 6 months. We performed field testing. Control cardiac MRI demonstrated no perfusion defect, no delayed contrast enhancement, no scar. So it is a clear success story. So, dear ladies and gentlemen, let me conclude. The pre-participation screening, especially in top athletes, is extremely important to reduce the risk of sudden cardiac death to be quite similar like patient at the population among unscreened non-athletes. I think sport is an extremely important things in our life, and I'm very much honored to be member of the Hungarian team during the Rio 2016 Olympic game, and I had a very small part in which was contributing to the success story of Hungary with 8 gold medals. So I would like to thank you very much for your attention.
Коллеги, заключительный доклад профессора Маркуса Вигема из Эстонии «Цифровая кардиология в Эстонии». Пожалуйста.
Dear colleagues, thank you for inviting me to the Russian Cardiology Congress. And I'm very pleased to report about the digital cardiology in Estonia. This is my conflict of interest. Somebody is teaching fees for several companies. Actually, Estonia, as you know, is an e-country. We have done quite a lot. We have e-government already dating back to 1997. We do not have any papers in the government. We have a digital ID, e-voting, and also we have quite a nice development in e-health. There are very many IT companies in Estonia. Usually they are small companies, young people involved. I think it's also similar in Russia. Russia now, IT is going on, and IT is getting very big importance. And it's 7% of GDP in IT sector in Estonia. Skype was developed actually, and it was discovered in Estonia. Now the development center is still in Tallinn, and e-health is rapidly developing also. There are several innovative e-solutions in Estonian healthcare. Almost all the health data are digitalized. All the prescriptions are digital. We have e-referral, e-consultation that have been developed during last years, and it's nice that GP can refer the patient, acute patient, or if it's absolutely not, the GP is not sure whether the patient needs to be hospitalized in 1 or 2 days or in 2 weeks. So e-referral is very nice, and our cardiologists are checking every day and inviting those most acute patients to the hospital. Of course, I'm not talking about myocardial infarction. I'm talking about other cardiac problems. And e-consultation is getting wider and wider in Estonia. It will not replace the normal consultation, the usual consultation, but in some cases it's helpful, and we can save time and also bring more benefit for our patients. And of course, electronic billing in healthcare. Very important is a patient portal. Every patient in Estonia can see exactly his or her health data, all the procedures, even the cost of the procedures, all the prescriptions, how much the drug costs, how much is reimbursed by the state, how much the patient has paid. So it has improved patient understanding of diseases and patient empowering. The patient are more and more deciding in his or her health, and compliance to treatment became much better. Here are the most important elements of the health information system. We have a hospital information system, as you see here. It starts 2008, and more elements have been developed. Family doctors, pharmacies. Very important was the prescription center in 2010. So it means that already for 10 years, almost all the prescriptions are digital, and me as cardiologist, very easy to see whether the patient really has purchased the drug in a pharmacy. And that shows compliance, and we can get much better understanding what's going on, and we are able to treat our patients much better. So a lot have been done in Estonia, but we are further developing, and you can see here there is a drug interaction database, which was a very important development starting 2016. So if I, as cardiologist, prescribe a drug, I can see whether this drug may interfere with some other previously prescribed drugs. And also important, on the left here, you can see the driving license health certificate application. That's very important because many, especially male patients, are not visiting the doctors. They are not very willing to come to the doctor, but they have to renew the driving license. And then we find hypertension, we find sometimes diabetes, and even serious heart diseases in some patients. And of course, the next step, what we are entering now, is a personal medicine and digital decision support system, meaning that already now we have in GP's office the system with the support advising to the GPs which investigations in addition to make for a particular patient, or warning if some drugs are contraindicated, or advising maybe you would prescribe some ACE inhibitor or ARB to the hypertension patients with kidney failure, or the diabetes patients. So it's very helpful especially for general practitioners. Genes are becoming more and more important, and for last year, Estonia has offered 100,000 residents to make free genetic testing. So in total, we have almost 200,000 participants in our genome bank. And it's very important for health. Here you can see our young Minister of Health, and they always, in a Minister of Social Affairs, they are supporting very much personalized medicine and genetic investigations. And there are two main personalized medicine projects going on in Estonia. One is oncology project in breast cancer, and second is cardiovascular prevention project. I'm leading this cardiovascular prevention project, and this personalized prevention project. As you see, there are family doctor on the like a key person assessing cardiovascular risk, and the main risk factors, as all known risk factors like elevated cholesterol, elevated blood pressure, smoking, etc. But the high polygenic risk score is added, which is becoming more and more important. And I can say in Estonia, our first data show that this polygenic risk score is at least as important as cholesterol or high blood pressure. We are now in the second phase of this project. We are developing a model. There is 1,000 participants wide randomized study ongoing, which will end at the end of this year, and then we can see whether intervention in those patients with a high polygenic risk score will improve cardiovascular risk, will decrease this risk, and how we can further develop personalized prevention in Estonian healthcare. This is the desktop. If I go to my outpatient office, here is one lady came to me from the eastern part of Estonia near the Russian border. And without this system, I couldn't know about her previous investigations, previous diseases. But here is very easy. I can see all the prescriptions. Here is prescriptions. I can see previous visit to different doctors. I can see all the procedures, all the investigations, all the epicrisis, previous ones. And it's for me as a doctor, it's very, very easy to work. And I've had several journalists from different countries. This translation was in a central TV of Germany. And the first question always is, what about the data safety? Whether this data cannot leak and the patient can be suspicious. But I can tell you that that the system is very safe, and also we can see who has approached the patient data, and the patient can see who has approached the data. So it's much safer than the paper. Here is the first cross-border drug prescription, which has started last year between Estonia and Finland. That's the first in the world. Also, Estonia was hosting last year the very first European Society of Cardiology Digital Summit in Tallinn, which took place in October last year, and it was a very, very big success. And we were supposed to have the same event this year in October in Tallinn, but that was cancelled, unfortunately, because of the COVID virus. But of course, this digital cardiology became so important for European Society of Cardiology, for American College of Cardiology, American Heart Association, also other national societies of cardiology. So we all together, we have to develop digital cardiology to improve the quality of care of our patients. Here is one of the roundtables on the Tallinn ESC Digital Cardiology Meeting Summit. And that was very, very creative, very, very successful. And this one example, that's one of my PhD students' work, showing that in Estonian GP practice, antihypertensive treatment depends very much on age. So the compliance is better with a higher age, and also the high compliance brings better blood pressure control. Thank you very much.
Спасибо большое профессору Вигема. Потрясающие успехи, конечно, в цифровой кардиологии. Но я думаю, что и мы не отстаем. Потихонечку цифровая медицина, я думаю, в ближайшее время, и как ни печально, коронавирусная инфекция подстегнула эти процессы в целом, и в том числе в здравоохранении. Коллеги, мы закончили нашу программу этого симпозиума. В этом же зале через уже 25 минут вторая часть международного симпозиума по актуальным вопросам кардиологии. Я всех приглашаю принять участие, а эта сессия заканчивается. Спасибо.